All right, so today's lecture we're going to be covering respiratory infections. And when we talk about respiratory infections, there's a lot of different kinds, and hopefully by the end of the lecture today, you'll be able to differentiate the different types of pneumonia, pediatric respiratory infections, and just kind of work through the signs and symptoms and how to differentiate them. As you can see, there are a lot of course objectives for the respiratory infections lecture, and that's because it's probably the most material dense lecture that we have in this module. And so I would definitely look at each of these and be able to have a very organized response to each of these course objectives. You'll notice in these objectives that there's also some tuberculosis questions or objectives, and these should be referred to with Dr. A's lecture that she's giving you aside from this lecture. One other thing I want to mention is that COVID-19 is obviously one of the newer respiratory infections that we'll be focusing on. However, that portion is not included in this lecture either. It will be covered by Dr. Hidalgo in our guest lecture. So what are we going to learn today? Essentially, our lecture outline includes pneumonia. And when we talk about pneumonia, there's actually a lot of subcategories that we're going to work through, including community-acquired pneumonia and hospital-acquired pneumonia, and also different categories that further differentiate them is atypical versus typical. We'll also touch on a couple of more specific types of pneumonia, like PCP pneumonia and mycoplasma pneumonia. We will touch very briefly on fungal disease, then get into some of the pediatric respiratory infections. And as I mentioned before, TB and COVID-19 will be covered elsewhere. So what is pneumonia? Well, pneumonia is an infection of the lung parenchyma. So not the airways, but the actual lung tissue itself. And when we think about pneumonia, we really generally classify it in two main categories. The first being community-acquired pneumonia, or CAP, or CAP, or hospital-acquired or nosocomial pneumonia, or HAP, H-A-P. Community-acquired pneumonia is the most common type. It occurs in the community, and the technical definition is any pneumonia that is acquired outside within the community or within the first 48 hours of hospitalization, because after the first 48 hours of hospitalization it will be considered a hospital-acquired pneumonia. So let's say you're admitted to the hospital for a knee infection, and on day one after admission you develop pneumonia. That would technically be considered a community-acquired pneumonia. However, if you're admitted for a knee infection or a knee surgery and more than 48 hours goes by and then you develop pneumonia, that would be technically considered a hospital-acquired pneumonia. And the reason why we really care, or one of the reasons why we really care, is because hospital-acquired pneumonia tends to have more virulent pathogens, harder to treat, more resistant, and the population tends to be sicker at baseline. When we talk about community-acquired pneumonia, it can be atypical or typical, and we'll go into that a little bit further later on. And the most common bacterial pathogen is going to be Streptococcus pneumonia, or strep pneumo. Okay. When we talk about hospital-acquired, there's a lot of less common types of bacteria that cause it. So E. coli, Pseudomonas, Staph aureus, those are the kind of infections we see. And a lot of these pathogens are highly resistant to antibiotics. First, we're going to go into community-acquired pneumonia a little bit more in depth. So it's really common. You're going to see this whether you're in family practice, internal medicine, or pediatrics, ER, urgent care. Approximately 4 to 5 million cases are diagnosed each year within the United States, and 25% of these are hospitalized. And if you see here, the next line I have, the deadliest infectious disease in the U.S. It's the 8th leading cause of death. So it is, of all the infections that we see throughout all the modules, it's the deadliest. We know that most of the time in mild cases, its mortality is really low. It's less than 1%. But amongst hospitalized patients, we have a higher mortality rate, 10 to 12%. That's pretty high. And then you see here some more statistics that those over age 65, within a year of having community-acquired pneumonia, you have a greater than 40% mortality rate, and that's really high. So it can be pretty devastating for older patients and those with comorbidities, age being one of those factors. And we look at risk factors for the development of community-acquired pneumonia, and some of the risk factors are those things that you would think about, right? So advanced age, that's a given. With pretty much any disease, as age goes up, for the most part, the risk factors go up as well. Other risk factors are alcoholism, and that's for multiple reasons. Generally speaking, when alcoholics drink a lot, they tend to become impaired to the point that they are not coughing well, they can't clear their sputum, sometimes they pass out, they throw up, and they aspirate, so they just have a higher risk of developing pneumonia. Also, tobacco use, we know that tobacco affects many systems within the body. Essentially, the smoking causes damage to the cell lining of the airways and impairs the body's mechanism for clearing pathogens, bacteria, and viruses and such. Other things like asthma or COPD obviously put you at higher risk, as well as immunosuppression. So when we talk about community-acquired pneumonia, first we're going to talk about the typical kind. And the typical kind, like we said, strep pneumo is the most common. It's approximately 2/3 of the cases. And there's some other main players in typical community-acquired pneumonia, which include H. flu and MCAT. And those three tend to be the main pathogens in the upper respiratory tract. So for, let's say, sinusitis, otitis, those are the same bugs that you see up there that can cause lower tract and pneumonia type infections. Other things that are less common are going to be the aerobic gram-negatives like Klebsiella and Staph aureus, which we'll talk about a little bit later. We won't go into too much detail, but we will go a little bit into kind of the ways to identify these different causes of pneumonia. In general, when we think of typical pneumonia, the classic presenting symptoms are chills, acute or subacute onset of cough, purulent sputum, usually thick sputum. You can have some cases that don't follow the textbook that are non-productive, but generally speaking, it's acute onset of productive cough with shaking chills, pleuritic type chest pain, and dyspnea. Those are the main symptoms that we're going to see. Other symptoms that you see are fever, hemoptysis, fatigue, myalgias, anorexia, headache, and abdominal pain. These are the main symptoms that we see. As far as signs, we see signs of at least sepsis or early signs of sepsis, including tachycardia, tachypnea. If the infection is really starting to spread, it can cause oxygen desaturation, and patients tend to appear pretty ill when they have pneumonia. On exam, when we have our physical exam, just like we've learned in patient encounter, you'll have late inspiratory crackles. You'll have these bronchial breath sounds, which, remember in our intro lecture, we talked about bronchial breath sounds being normal kind of in the trachea area, or where the trachea splits. That would be a normal breath sound there, but bronchial breath sounds that you hear out in the periphery of the lungs, that's abnormal, and it tends to go along with pneumonia. Other things we see, increased tactile and vocal fremitus, because that goopy disgustingness that happens within the lungs actually increases the amount of vibrations that are transmitted through them. Also, because you have more dense pus-like accumulation, you get dullness to percussion where it's usually more air-filled. And you can have egophony, which is when you put your stethoscope on the patient, you have them say E, and when you hear it, it actually sounds like A. And then also the whispered petroliloquy, where you have them whisper something and it sounds more amplified because of the infection. And these physical exam findings, most of them are localized to just the area of pneumonia. As we'll see in a few minutes, these typical types of community-acquired pneumonia are generally lobar in nature, meaning that they tend to pick a lobe of the lung and kind of set up shop there and start deteriorating that lung in that area alone. So how do we diagnose community-acquired pneumonia? There's a bunch of testing that can be done, and kind of putting it all together with the history and antibiotic therapy is generally empiric in nature, meaning that we don't always have to do this huge diagnostic workup for everyone that has symptoms of community-acquired pneumonia, because at the end of the day, we end up using empiric antibiotic therapy most of the time. We recommend diagnostic testing for those that are pending hospitalization, especially if the pathogen is not going to be responsive to standard care. If we're worried about antibiotic coverage, that we want to kind of narrow it down as much as possible. And then obviously in more acutely ill patients, we're going to want to get more testing to try to target the specific pathogen for their infection. So what kind of testing is there to be done for community-acquired pneumonia? Most of the tests tend to help narrow the diagnosis. So we have sputum and gram stain and culture. That's where we have the patient kind of cough or expectorate whatever the sputum that they have, and we run gram stain and culture on that to try to amplify it and figure out what it is that's causing it. For strep pneumo and Legionella pneumonia, there's a urine antigen test that we can run that'll help us determine if that's the cause. Other things that we tend to do are the rapid viral test that helps us kind of rule those players out, and that's the rapid flu and then of course the COVID testing. Not SARA, but SARS. Also, not often, usually we can differentiate without having to get this, but there are tests for tuberculosis, and they also have these rapid PCR tests that are done. They kind of have like a shotgun approach to all the different viruses and mycoplasma that can kind of test for a bunch of different things all at once, and that uses kind of a nasal wash or nasal swab. Other testing, so if patient's hospitalized, you're definitely going to want to get a CBC with differential. Usually patients with community-acquired pneumonia have an elevated white cell count. We're also getting a complete metabolic panel or a basic metabolic panel. I tend to get more complete metabolic panels to look for changes in glucose, electrolytes, BUN, creatinine, and then liver enzymes and such. For patients that appear toxic and are pretty hypoxic with their initial vital signs, you can consider getting an ABG to look for the acid-base status and to look to see how hypoxic they are. And then for any type of infection, especially pneumonia, we tend to want to try to get blood cultures, at least 2, pre-treatment if possible. And in most cases it is possible. And then to round out your blood work, usually get a lactic acid, kind of helps you differentiate sepsis. So imaging. Chest x-ray is what we do. If you ask you what the best initial test is, it's going to be a chest x-ray. In most cases of community-acquired pneumonia, a chest x-ray is all you need to make and confirm the diagnosis. Most of the time you can point out exactly which lobe is affected. You have to have at least some sort of finding on chest x-ray or CT to be able to establish a diagnosis of community-acquired pneumonia. And CT is definitely more sensitive and specific, but it's not always indicated, so you have to kind of pick and choose which cases you feel warrant that. You can't really tell by the way that it looks on a chest x-ray exactly what's causing it, like which pathogen it is. But if you see multilobar disease, like more than one lobe, or bilateral pneumonia, that indicates more serious illness, and you should take those patients very seriously and admit them to the hospital. You'll also monitor chest x-rays to help assess severity and response to therapy. So as the patient is admitted to the hospital, if they're showing kind of a lack of improvement radiologically speaking, and of course clinically speaking, it's poor prognostically. It means that there could be some sort of other alternative pulmonary process going on, because generally speaking, these types of infections are pretty responsive to antibiotics if you're using the right ones. Also, for as far as like clearing pneumonia, it can take up to 6 weeks, even more, to clear an infection on chest x-rays. So you can't use that as kind of a means to decide when to discharge a patient from the hospital. Of course, you should see some improvements, but it can take up, like I said, up to 6 weeks or more for it to completely clear. And on this picture here, you can clearly see a pneumonia here in the right lower lobe area. And it's really important to always try to get 2 views because the heart's in the way, and sometimes you can have these retrocardiac pneumonias that can be really hard to see without getting the lateral view. And they also kind of help you just see the extent of the pneumonia, so you can clearly see it here. So how do we treat community-acquired pneumonia? Well, there's 2 general principles that guide antibiotic therapy once we know that it is community-acquired pneumonia. We have prompt initiation of medication and which pathogen is which antibiotic is the pathogen susceptible to. So we have to think about those things, kind of thinking about the history of the patient, the way that the chest x-ray looks, and whether it's community-acquired or hospital-acquired. One other thing that you have to consider, which is very important, especially in emergency situations or in the clinic, is can this patient go home and be treated outpatient, or do they need to be hospitalized? And this is, of course, multifactorial. You have to consider how old the patient is, comorbidities, vital signs, to decide whether the patient needs to be admitted or not. And I do have a slide on that coming up, where we'll go through 2 ways that you can kind of assess the patient's morbidity and mortality related to their symptoms and their laboratory findings, and kind of help yourself make an educated decision about whether they can stay, whether they need to stay or whether they can go home. Like I mentioned before, empiric therapy is usually what we go with. Obviously, if we get sputum or blood cultures, they're going to take a while to come back before we actually know what's causing the patient, if we even get a positive result. So we use empiric therapy. And there's different treatments for different categories. I have a few slides coming up, and you'll notice that, there's, depending on their comorbidities, whether it's inpatient or outpatient or ICU, there's different regimens to do for the patients. And when we're talking about outpatient therapy, we want to consider those that are healthy with no recent use of antibiotics. They get 1 set of drugs, and then older adults with comorbidities and those who've received antibiotics within the past 90 days receive a different treatment. In addition to antimicrobial therapy, which is the mainstay of treatment for pneumonia, there is a place for corticosteroids. However, routine corticosteroids are not indicated, so usually reserved for those with asthma or COPD, with exacerbation related to the community-acquired pneumonia, and those that have severe septic shock. Other supportive care, especially for those that are admitted to the hospital, is going to be chest physiotherapy, where you have respiratory therapists that essentially come and kind of beat on the patient's chest to kind of break up any mucus and help them expectorate. And also incentive spirometry, which is kind of a little apparatus that encourages patients to take big deep breaths and breathe out forcefully, because when you have pneumonia, it can tend to be painful. You get pleuritic type chest pain, and these patients don't like to take big deep breaths, and this then can kind of make the situation worse with deconditioning and such. So those are a couple things that they tend to do when they're admitted. We also monitor their oxygen, give them oxygen supplementation. A lot of these patients have fever and pain, so we treat that. And a lot of them require fluids. They're not eating and drinking properly. They're losing excess fluids through the hyperventilation. And then, of course, keeping track of their diet and activity. So this is straight from your textbook, the current textbook, and it's the recommended empiric antibiotics for outpatient management of community-acquired bacterial pneumonia. Generally speaking, now I always like to mention there's a difference between street med and book med. In this case, StreetMed and BookMed kind of line up. What they say here is that for previously healthy patients with no risk factors for MRSA or Pseudomonas, and that have not received antibiotics within the last 90 days, we can give them one of three things. We can give them amoxicillin, we can give them doxycycline, or we can give them a macrolide. But I will tell you, generally speaking, azithromycin is what we give. One, because it's easy to take. It's a Z-Pack, essentially. It's easy to take. It's only 5 days of treatment. And it is, it's easy to take. So that is usually what we go for first. I'm not 100% sure about our local macrolide resistance for strep, but this is what I see used most often in emergency room settings. Another reason why is because it works also very well for atypical type pneumonias, so you kind of get double coverage in that regard. If you have patients that have any risk factors, comorbidities, other issues, then the recommendation is to give a macrolide or doxy plus an oral beta-lactam, or you can give monotherapy with an oral fluoroquinolone, which is essentially moxifloxacin, levofloxacin, really anything but ciprofloxacin, because there's not good penetration to the lungs. Now, it starts getting a little trickier when we talk about inpatient treatment of community-acquired pneumonia. I don't know that I would actually make you regurgitate this amount of information. I think it's a little bit excessive. But you should know that, generally speaking, respiratory fluoroquinolone is indicated. You can also give a macrolide plus a beta-lactam. You can give, for those patients that have MRSA, you can give some coverage for that. So you just kind of have to work through this algorithm. And if you go to the ICU, it's even more aggressive therapy. So you can take note of this. I'm sure we'll cover it as well in Pharm if you haven't already. But essentially speaking, you should be familiar with the classes of drugs that are generally given. So again, I love MedComic. I think it's an easy bird's eye view to kind of figure out different conditions. And you can see all the little things that we've just talked about with typical community-acquired pneumonia. So we just talked about typical community-acquired pneumonia. Now we're going to talk just briefly about atypical community-acquired pneumonia. So typical, we said, was acute onset of cough with fever, chills, dyspnea, and pleuritic type chest pain, right? Productive cough, we said. Whereas atypical tends to present more insidiously. So it kind of comes on or kind of creeps on over days to weeks. Generally speaking, like layman's term for this would be like a walking pneumonia. And mycoplasma pneumonia is the most common bacterial cause. Other things that cause this more atypical type are viruses, like these viruses here, as well as Legionella and chlamydia. That's not the chlamydia that you're thinking about for STIs. It's different. It's in the same family, but it's different. Now, symptoms that we see for this, like we mentioned, it's more insidious, kind of creeps in. You get more of a dry cough, less sputum production, and you tend to get more of a low-grade fever and kind of a sore throat and a few other kind of more generalized symptoms with it. Some signs that you see is this pulse temperature disassociation, and that's essentially when you have a fever, you actually have a normal pulse, which is also suggestive of atypical pneumonia. Other things that you can hear on physical exam would be wheezing, rhonchi crackles kind of scattered throughout. On chest x-ray, they say that the chest x-ray for community-acquired atypical pneumonia actually looks worse than the typical type, because you see kind of this diffuse diffuse reticulonodular infiltrate. It kind of looks like it kind of spreads all over the place. And then in certain cases, you can have kind of minimal consolidation. So you don't really see it in one specific lobe. You kind of see it scattered throughout. Like we mentioned in the previous slide, mycoplasma pneumonia is the most common type of atypical pneumonia. It can cause just a simple upper respiratory infection, or it can cause lower respiratory infections. And it causes other types of extrapulmonary manifestations. But most of the time, how these patients present is they kind of have this period of just slow progressing cough, and it can progress for weeks, even months. That's why they call it walking pneumonia, because you're kind of walking around with it for a long period of time. You also get kind of a malaise, low-grade fevers, some sore throat, a headache, and patients generally, especially in vignettes for exam, they like to put, that they are a student in college or in the military or some sort of close quarters, because it tends to be easily spread from person to person. How do we diagnose it? We chest x-ray. You can get a culture. There's also a PCR serology that you can do that helps you. It'll basically tell you if that's what it is or it isn't. You don't need that to make the diagnosis. You can make it clinically with a chest x-ray and then treat it. Like we said before, macrolide tends to be the treatment of choice, similar to the typical pneumonia. So Z-Pak tends to be first line. You can also give doxycycline, fluoroquinolone, although we tend to reserve fluoroquinolones for more advanced cases of pneumonia. It says here, just like we mentioned before, that you want to be aware of your local antibiotic resistance patterns. So, pun intended, these are your mnemonics. If you have trouble remembering the difference between the typical pneumonias and the atypical pneumonias, here's a couple of quick ways to try to remember them. For me, I kind of just remember them, but if you're having trouble, here's a way to think about it. So this is kind of my disclaimer slide. It's where I kind of throw a lot of different things at you and give you kind of generalizations, although there are no absolutes in medicine, but there are common trends, and especially in the testing world, when we do standardized tests, they like to throw the same kind of things at you as kind of trigger words or buzzwords that we tend to hear. So when we think of Klebsiella pneumonia, it tends to come upon us in alcoholics, and those it causes a current jelly sputum. So current jelly essentially looks like reddish colored jelly, like the kind you put in a peanut butter and jelly sandwich, and that is pathognomonic for Klebsiella pneumonia. For mycoplasma, remember we mentioned just briefly that it's usually close quarters, so college students, military. For TB, tuberculosis, it tends to be more immigrant status or patients that recently moved from other places, although that's not an absolute, like I mentioned. COPD patients tend to get H flu, so Haemophilus influenza type pneumonias. In Legionella, they tend to mention something about exposure to aerosolized H2O, like those misters, or contaminated ACs. It actually comes from a conference, a Legionnaires conference, like way back when, where a bunch of attendees at the conference got the same type of symptoms, and that's kind of how it got called Legionnaire's disease or Legionella. And it's also common in organ transplants. These patients also in their vignettes tend to have this relative bradycardia, like we talked about, where when you have fever and you expect the pulse to be up, it's actually low. And then they tend to have this confusion or neurologic symptoms like confusion, and they have like diarrhea and vomiting associated as well. HIV positive patients, as you probably remember back from your immunology module, they're their own set of difficult, right? They're very difficult patients because so many pathogens tend to cause kind of strange or non-typical types of infections. The one that they tend to test about in the way of pneumonias is PCP, and so it's good to note here that other pathogens like strep pneumo is actually more common than PCP, but whenever we see patients that are immunocompromised, severely immunocompromised, we think PCP. For post-viral pneumonias, so let's say someone gets influenza and they clear the influenza, but then they get sick again, or they get even more sick. Staph aureus tends to do that. And Staph aureus is also common nosocomial bug. And last but not least, group B strep is the number one cause of neonatal pneumonia. And that's usually, it says 0 to 2 months, but it's usually a month or less. It's usually several weeks. So babies that get pneumonia tend to get group B strep, and they get it from their mother. And that's why we test for group B strep late in the pregnancy. And if we don't know the mother's GBS status, then we tend to give antibiotics at birth. Here's the book's version of the different pneumonias and kind of how they present differently clinically, and some of the complications they can cause. So it's similar to what I just showed you, but a little more complex, a little more detail to it. Like we mentioned earlier, it's really important when you're in the emergency room setting or even outpatient to know when to admit. When do I need to admit a patient with pneumonia? And the diagnosis is made. So we make it with our clinical picture, our physical exam findings, and our chest x-ray, maybe some lab work. The first decision is to determine whether it's safe for the patient to go home. Safe for the patient meaning, is their illness going to worsen to the point that they might have severe morbidity or mortality, or can they take care of themselves safely at home, or do they need to be admitted to the hospital, right? And so there's two widely used prediction values that we use. The Croup 65 is a little more simple, and I'll go through each one. And then we have the PSI, or the Pneumonia Severity Index, and those two help you as a clinician decide whether you need to admit the patient or not. And like I mentioned before, you want to include, when you're thinking about whether to admit or not, the general rule of thumb is if they're 65 or more, you have to have a pretty low threshold for admitting them. Anyone with significant concomitant illness like cancer, COPD, CHF, immunocompromised, you really don't have to go through these indexes and Croup 65s. You should just know this patient probably needs to be admitted. So here's a nice fluid algorithm from UpToDate that kind of takes you through determining the approach of the safe side of treatment for adults. I don't expect you to know every single path down this, but if you think about it logically, it kind of takes you through the different things that you would need to assess for before you decide whether the patient can go home or they're going to be admitted, and whether they're going to be admitted to the ICU or to the general medical ward. This is the PSI, the Pneumonia Severity Index, and as you can see, you start off with step 1 over here. So you're looking for any one of these things to be positive. So if the patient's 51 years old, bam, you already have one positive, you move on. If you have a yes, you move on to step 2. And you can see the list here of all the different things that are included in step 1. Once you move on to step 2, is start calculating, start adding points up. So you get a few points for being a man, you get a few points off for being a woman, and then you add all the points up based on physical exam findings, coexisting illnesses, whether they're a nursing home resident or not, and some laboratory findings, and you come over here once you have this tally and you put them in a risk class. Low being 1, and based on algorithm, that would be a 0.1% mortality. Now, as you go up, the percent of mortality goes up along with it. And so this is what you should gauge or use to help you decide whether or not the patient needs to stay inpatient or not. Like I mentioned before, Croup 65 is kind of a simplified version of assessing for patients' disposition. And it uses a lot less criteria. So the age is a little higher here. It was 50 on the PSI, it's 65 here. You're assessing blood pressure, respiratory rate, BUN, and whether or not the patient is confused. And in this assessment tool, there's 3 main categories, and it makes it pretty easy. Either go home, they need to be admitted, or admit and manage as severe. So shifting gears here, we just finished talking about community-acquired pneumonia. Now we're going to talk briefly about hospital-acquired pneumonia. Hospital-acquired pneumonia, as we mentioned before, has a pretty strict criteria for what qualifies as hospital-acquired pneumonia. Any patient that develops pneumonia after 48 hours of admission to the hospital is considered a nosocomial or a hospital-acquired pneumonia. Similar to as the subcategory, which is ventilator-associated pneumonia or VAP, that is if you develop pneumonia after 48 hours of being intubated. Okay. The reason that we mentioned that these cases are a little more complex is because hospital patients carry flora with resistance patterns that are a lot more crazy, I guess, than healthy patients do. And their health status, the fact that they're already in the hospital, makes them higher risk for severe infection. The most common, like we mentioned before, are going to be gram-negative rods like E. coli, Pseudomonas, and then also Staph aureus. Signs and symptoms, it can be kind of nonspecific. If you have fever, along with kind of new opacification on chest x-ray, that should trigger you to think of more of a nosocomial pneumonia. And then the treatment can be quite complex. You want to get 2 blood cultures from different sites before you start antibiotics. And you're going to assess risk factors for MRSA, multi-drug resistance, and you're going to consider local antibiograms. So within each hospital system, they have kind of their go-to drugs because their pharmacists in-house kind of keep an eye on the bugs and resistance rates locally. And so they kind of help direct your choosing of whichever antibiotics you'll need. These are the recommended hospital-acquired pneumonia and ventilator-associated pneumonia drugs. Now, I'm not going to test you on this. It is quite complicated, and there's a lot of different choices, which, like I mentioned before, it's going to be pretty specific to where you're working, whether locally, which region of the country you're working in, their local resistance rates, and then really what's located on your hospital formulary. And each hospital has a different formulary that they use. And here's one more chart. These are the high risk of mortality patients. Okay. These are the risk factors that we talked about for multi-drug resistance and Staph aureus and Pseudomonas. So you'll see there are different risk factors to consider when deciding which drugs are needed for which patients. So as far as prevention is concerned, we know that we have several different options or choices for prevention. Now, influenza vaccine should be given every year, right, for all pretty much anyone, especially healthcare workers, patients with comorbidities, and that's a yearly vaccine. The pneumococcal vaccine should be given to patients 65 years or older, or those that are younger that have other things like immunocompromised state, heart disease, sickle cell, asplenia, alcoholic cirrhosis, diabetes, lung disease, pulmonary disease here. And then one that's not on here, which we will touch on in the COVID-19 lecture, would be the COVID-19 vaccine in their series that you would get to prevent that infection. So kind of shifting gears again, we mentioned that we were going to talk really briefly about PCP, or pneumocystis pneumonia. This pneumonia, I don't know why they really like to test on it on standardized tests, and it tends to be pneumonia that we see in immunocompromised, especially those with HIV and AIDS. Patients tend to present with fever, dyspnea, non-productive cough, and hypoxia. You can hear adventitious breath sounds on auscultation, and some you don't really hear anything. You can do a culture of the sputum, bronchoalveolar lavage, especially in those that are intubated. And chest x-ray usually shows kind of this bilateral interstitial disease. And in AIDS patients, you'll see up to 80% of AIDS patients not receiving prophylaxis is a major cause of death. And treatment is trimethoprim sulfamethoxazole, kind of Bactrim, right? So primary prophylaxis for PCP should be given to patients with a CD4 count of less than 200 and a CD4 percentage below 14%. So, and the other thing that you can give it for, even if they're not that low, is anyone with significant weight loss or oral candidiasis, because those are indicators of advanced disease. Okay, so now moving on to fungal disease. Now, we've kind of gone into a lot of depth on just pneumonias. You'll notice I put a lot of emphasis on community-acquired pneumonia, both typical and atypical. We talked about that pretty in depth. Then we kind of skimmed the surface for nosocomial pneumonia. We didn't go into as much depth. Same thing for some of the more specific types of pneumonia. We kind of just covered the general kind of bird's eye view of it. For fungal disease, we're going to do exactly the same thing. This is not something you need to know everything about. It's something you need to know a little bit about everything. Okay, so when we talk about the different fungal diseases, this chart kind of has it all. Your textbook has a little more information on this, but this is kind of the gist of what I would like for you to know. These are the main kind of culprits for pulmonary fungal disease. We have blasto, coccidio, histo, crypto, and aspergillosis. So we'll start with blasto. A lot of times how these present in vignettes, it's not something that you'll probably see very often, if ever, in your career, any of these mycotic diseases. But if you do, you kind of have to just expect it, even though it's not very expected. But on tests, it's a lot easier to diagnose because they give you those hints and clues that you need to make the diagnosis. So generally speaking, with blasto, you can get this disseminated disease with fever, you get night sweats, and you can get these granulomas, skin, lung, and elsewhere. You get weight loss associated too. Usually these are east of the Mississippi River. They like to say that. I had to look it up because I didn't know exactly where the Mississippi River traveled. But essentially anything east of the Mississippi River, and we think about it also in kind of Central America as hot, humid climates. And it tends to come from the soil, like most fungus do, or in rotted wood. It is a yeast, and you can inhale it, and that's how you kind of get it. And you can do some histology cultures, and the treatment, depending on the severity of disease, is going to be one of these. Don't quote me on these treatments. They're kind of empiric type antifungals. I would definitely consult your pharmacy class for that. Moving on to coccidio. When I think of coccidio, I think of the C in coccidio. I think of kind of California, Latin America, Southwest USA. It's endemic to that area. For these, they usually get this mild lung infection. Sometimes it's actually even asymptomatic. You can also have this kind of mild pneumonia, and a lot of times in vignettes they'll throw in this erythema nodosum, which is this nodular red rash that you get, especially on the extensor, or like the shins and the forearms, extensor surfaces. You can also get this disseminated disease that can lead to granulomas on the bone, even meningitis. Then looking at the pathogenesis, it's inhaled, and there's some serologic testing available and the same kind of treatment. Histoplasmosis is the one I see tested the most. And when I see histoplasmosis, I see bird and bat droppings in the soil. Okay. So they love to test on this, and they almost always mention something about the Ohio or Mississippi River valleys. And the way that I remember it is that in histoplasmosis, I think I remember that it has Ohio in it. And that's how I remember it. With these, they tend to get either kind of an asymptomatic infection or kind of this atypical pneumonia, like kind of what we talked about. When you have immunocompromised patients, and these infections tend to happen more in the immunocompromised population, they get kind of more of a disseminated disease. Again, same kind of stuff this away on the chart. For crypto, we're going to see it's with soil, like bird droppings, especially pigeons and droppings, and doesn't really have an endemic area, but sometimes patients can be asymptomatic. If you can get cryptococcal meningitis, more granulomas, and pneumonia, and it's a yeast that you inhale. Last but not least, aspergillosis is it can be pretty much anywhere. There's not an endemic area. But again, you inhale the airborne candida, and then it can cause invasive necrotizing pneumonia, or you get these like cavitations. That's mostly in immunocompromised. Then you can get these aspergillomas in other places, and that requires surgery if you get those. So that's about the depth that I think you need to know for both your PANCE and for my exam. I will have a few questions kind of sprinkled throughout, and I will have a case. It won't be on our infections day, but I will have a case about fungal disease that we'll work through a little more in depth. All right, so we are 45 minutes into this lecture. We're doing really well. If you need to take a break, this would be a great time to kind of pause, take a quick break, stretch your legs out, and then come back and push through the rest of this lecture. The next disease that we're going to talk about is acute bronchitis, and this is probably way more common than anything that we've seen up to this point. It's an infection of the airway. Remember, we said pneumonia was infection of the parenchyma of the lung. This is an infection of the airways of the lung. And usually viruses are the majority of the culprits for this type of infection. In most cases, you don't really need laboratory testing. You can get a chest x-ray, mainly if you're considering that it could be pneumonia instead, kind of to rule out pneumonia. And if you don't see anything, usually you don't see anything with acute bronchitis, and the patient has kind of this fever, a little bit of tachypnea and stuff, you would think it would be more pneumonia, but if you don't see anything on the x-ray, it's probably acute bronchitis. How they usually present, it's usually cough. I always think of the lady, that sweet brown, I got bronchitis lady. That's the lady I think of when I think of bronchitis. But they usually, with or without sputum, that's usually what they come in with, and it can be 1 to 2 weeks of this cough, kind of consistent cough. Sometimes they have a little bit of fever. They might have a little bit of chest discomfort, especially from the recurrent cough, and sometimes a little bit of shortness of breath or kind of reactive airway process. Since most of the causes of acute bronchitis are viral, antibiotics are not always indicated, although if you're considering that it possibly could be, most of the time we tend to give either a Z-Pak for this or amoxicillin. as well as cough suppressants. I try to stay away from codeine-containing cough medications because of dependence and abuse, but sometimes the patients just cannot get any relief, and that's kind of what you have to resort to. Other things, since it is an infection of the airway itself, some patients do benefit from bronchodilators like albuterol. So if they come into the ER and you try it and it helps them, you can send them home with the same type of medication, whether in a nebulizer form or in an inhaler. Epiglottitis, tend not to see it as much anymore because of the immunization for HIB, Haemophilus influenza type B. Kids are vaccinated against that routinely, so we don't see it very often in the pediatric population anymore, but it is something, because it is so life-threatening, that we have to be able to recognize it when we see it. And generally speaking, it'll be in an unvaccinated child. So you get inflammation, swelling of the epiglottis, which, if you'll remember from anatomy, is that kind of flap that prevents food and liquids from passing down into the airway. And in this infection, it gets inflamed and swollen to the point that it essentially reduces the amount of air that can fit down our air pipe. And kids usually appear very toxic. They get abrupt onset of dysphagia, which they have trouble swallowing or pain with swallowing. They get drooling and they get distress. Hot potato voices, like when you're talking, when you have something hot in your mouth. And then they also posture. So they have kind of this tripod where I'll show you a picture of it in a minute. They kind of lean forward and they kind of stick their neck up and out like they're sniffing the air. And that's to kind of physiologically open up the airway as much as possible. One of the main things they love to test about on epiglottitis is securing the airway first. Because it's so swollen and these kids are in distress, you try not to agitate them as much as possible. So limiting x-rays, IV sticks, injections, taking the child away from their parents. You try to limit that as much as possible, and you got to get the right people in the right place at the right time, right? So you got to get airway experts, pediatric expertise, anesthesiologists, get them in the ER quickly to get these patients intubated. I would say that all pediatric patients with epiglottitis get intubated. Adults, not so much. Adults tend to present a lot less acutely, a lot less severe, and I would say only about 10% of adult patients get intubated. But with pediatric patients, it is a true emergency. Once you have the patient stabilized, the treatment is antibiotics, is usually cephalosporin type medication and some sort of anti-staphylococcal medication. It is said that George Washington died of epiglottitis. So that's interesting. Just a little fact I'd like to throw in there. These are some of the findings that you would see. So this is that sniffing position, neck kind of stretched out, mouth open, kind of stretched up and out, kind of gasping for air. This is the tripod kind of mixed with a little bit of a sniffing position, kind of sitting up and forward with the neck extended and the mouth open. This right here is a radiologic finding called thumbprint sign. So if you take your thumb and you put it there, you'll notice that the epiglottis here is swollen. The normal epiglottis should look almost like a little flap, like a coin here. And this is much thicker. So we know that that is definitely abnormal. So you can kind of see it here. It should look more like this, and it looks like this. This is another picture. This is a normal epiglottis here, and this is an infected epiglottis. And as you can see, there is no room for air to pass, and that is why patients die when they have epiglottitis. Moving on, next we have bronchiolitis / RSV. And the reason I put these two together is because they have essentially the same clinical picture. Not all cases of bronchiolitis are caused by RSV, but most are. So bronchiolitis is this constellation of symptoms, low-grade fever, tachypnea, wheezing, a little bit of cough, and kind of URI type symptoms that go along with it. And RSV is a virus that causes bronchiolitis. It's the most common cause of bronchiolitis, and it's a paramoxiovirus. It's the leading cause of hospitalization in kids under 5 years of age. It's also one of the major causes of pneumonia in that category. let's see, what else can we say? Bronchiolitis, when I think about bronchiolitis, I think about an infection that causes kind of this asthma type picture plus infection, because it is an inflammation or infection of the bronchioles, which are the smaller airways. And so you get a lot of air trapping, you get wheezing, increased work of breathing, low-grade fever. In most cases, young kids with RSV tend to do very well with supportive care like hydration. If they come in and they're having a significant amount of trouble, then we have to consider admission to the hospital. And those that have to be admitted to the hospital, we have a slide coming up next on that. We need to consider that. So a lot of patients do well with humidified air, nasal suction, and supportive care for like fever, rehydration. You don't always have to get a chest x-ray for straightforward cases, but if you do, it might or might not show some hyperinflation and kind of symptoms of air trapping because of the parabronchial thickening. When to hospitalize, so admission criteria in little kids, because it happens in kids, RSV, it happens in adults too, but we don't have the same reaction that kids do. Kids have a very narrowed airway, and so with just a little bit of inflammation, they tend to present a lot more sick than an adult would. So any kid, I tend to be careful around 6 months even, 6 months or less. I consider admission highly. 3 months or less is a given. They're going to be admitted to the hospital because they use a lot of work. They have a lot of signs of respiratory distress. They have a lot of accessory muscle use. And so when kids have to work that hard to breathe for a long period of time, they don't do well. They tend to tire out, and then we have a problem, especially if they're home and not in a hospital setting. Any patient that's hypoxic, if they're so tachypnic, this is extremely tachypnic, you'll admit them. Anyone using accessory muscle use, cyanosis, of course you'd admit, and any of these other things would be indications for admission. RSV also tends to happen in the Christmas months, so kind of in the winter. And it's really common to be passed from kid to kid in like the daycare setting. So definitely want to ask about sick contacts when you talk to your patient. The next pediatric illness we're going to talk about is Croup, aka laryngotracheobronchitis. The common cause of Croup is going to be the parainfluenza virus, and there's different types. It's common in young children, 3 months to 5 years old. And essentially it's inflammation of the subglottis. So everything kind of below kind of the vocal cords, the top of the trachea in that area. And so because it is inflammation of that area, we tend to hear hoarseness, URI symptoms with hoarseness, inspiratory stridor, which is kind of this noise that you can hear. Symptoms tend to be worse at night. And the hallmark symptom that we see is this barking cough. And I can tell you, when I'm working in the emergency room, I can hear the cough coming down the hall. I mean, if you hear this kid cough, you'll hear it sounds like a bark, like a seal or a bark, and you can tell that it's them kind of honking with that cough down the hall. And by the time you walk in, you almost already have your diagnosis. Of course, you want to keep in the back of your mind these other things we've talked about, like especially epiglottitis. But in most cases, it's an easy diagnosis to make. On x-ray, I hardly ever get x-rays on Croup because it's so easy to make the diagnosis clinically. But if you do get that x-ray, you can look for what they call the steeple sign. So this is a steeple of a church, this narrowed out area. And as you can see, the airways here, and it just kind of thins in that subglottic area. And that's considered the steeple sign. It's a x-ray radiological finding that's consistent with Croup. Also, kids obviously that have their airway completely narrowed off here can be hypoxic and have both inspiratory and expiratory stridor. And with the stridor, you know that things are getting even more inflamed. So you have a threshold for admission, kind of similar to the admission criteria that you considered for bronchiolitis. How do we treat these patients? It's a virus, so there's no antibiotics involved. In most cases, supportive treatment is all the kids need. A cold mist humidifier to help reduce inflammation in that airway. Also, if they're severe enough in the ER, we give them a nebulized racemic epinephrine. And when we do that, we actually should monitor the child for at least 3 hours to make sure there's no rebound, closing of the airway or tachycardia because of the epinephrine. And last but not least, we give the children dexamethasone, so corticosteroid, 0.6 milligrams per kilogram. We can give that orally or IM or IV, depending on the patient. Influenza, everybody knows about the flu. I would say that almost all of us have had it at one point or another in our lives. And if we haven't, thank goodness, because it's awful. It is an orthomyxovirus. That's a mouthful. The incubation period is about 1 to 4 days. It's usually epidemic, right? You pass it from one person to the next. And the way that these patients present, like it's like a truck hit them. It's an all of a sudden fever, chills, malaise, just fatigue, cough, coryza, and myalgias. They just feel achy. They can't move. They feel like a truck hit them. And a lot of times they'll tell you, oh, so-and-so that I was next had the same symptoms, or kids at school had the flu or whatever. Or a lot of times they're unvaccinated. You usually get a rapid flu antigen test. I mean, not strep flu. Although most of the time when patients come into the ER, we tend to get the rapid flu and strep because it kind of covers our bases. Treatment is going to be treat the symptoms and bed rest with the addition of Tamiflu if they're within the first 72 hours of illness. The sooner we get Tamiflu on board, the better the outcome. So earlier you can initiate, and there is some prophylactic doses for those that are within the same household that have a patient with positive flu. And of course there's different types, type A, type B, doesn't really matter. You get the test for both and you treat it accordingly. Pertussis is the last, we're at the end, thank goodness, right? Pertussis is the last thing we're going to talk about. When we talk about pertussis, it's whooping cough. It's another one of those diseases that we don't see very often because we're vaccinated. So anytime we have the Tdap or DTaP vaccine, so the same one that we get for tetanus, we are vaccinated for pertussis as well. So most of us got the vaccination series when we were younger. Babies don't get it until later on. So especially in infants less than 2 months, they're very vulnerable to this infection. They can have very bad outcomes. So it's recommended that actually all those in the household, including the pregnant mom, be vaccinated against pertussis so that they don't bring it in to the house of this brand new baby. The way that whooping cough is described is in phases. So the first phase that we have, well, it's transmitted by droplet infection, so it is contagious. The first phase is the catarrhal phase, okay, and that usually lasts about 1 to 2 weeks. It's that cold type phase, so they get a little bit of cough, some runny nose, conjunctivitis, and the cough, a little bit of cough at this point. Then we go into the paroxysmal coughing phase. The paroxysmal phase is kind of like the classic whooping cough, where you get these fits of coughing. They're lasting usually about 2 to 5 weeks, and they get like this 4 or 5 staccato cough, or kind of a machine gun of coughing, and then this very quick inspiratory whoop. So it's cough, 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 like that, and that's the whoop in the whooping cough. It's not the same whoop as the whoop, there it is, from, I don't know, 90s? No, never mind. So that's the paroxysmal coughing phase. And then we have the convalescence phase. The convalescence phase when we start getting out of the window of having the infection. That usually lasts about 1 to 2 weeks. Start seeing a slow decline in the cough, and then they start getting better. A lot of patients that have this tend to get these hemorrhages because of the violent coughing fits that they have. They also get a lot of post-tussive emesis, so throwing up after coughing so violently. You can get pneumonia as well, and essentially That's whooping cough. You might see it once or twice in your career. I've never seen it, but the treatment is going to be macrolide as well. So usually Zithromax. And that is it. We finished. It took us a little less than an hour to get through this lecture. It's not the only lecture. I would certainly go and watch some of your supplemental videos. I really like Paul Boland's videos. I like your osmosis videos, and I posted them for you in your supplemental video folder on Blackboard. So take a look at those additional resources, especially if you want to kind of add to the information that I've given you. And hopefully you can apply this knowledge to the cases that you'll work through with your group. So I hope you enjoyed this lecture. Let me know if you have any questions, and I'll see you in class.